grand round. As we've just indicated, the recording, we have a recording of this session. However, during the question and answer period, we will stop recording in order for people to ask and answer questions frankly. I'd first like to start with the land acknowledgement. Ramona, could you advance the slide, please? So we'd like to begin with an acknowledgement of the land on which we work, study, and live. We recognize that many Indigenous nations have long-standing relationships with the land upon which the work of the University of Toronto's Department of Medicine is conducted. We acknowledge our presence on the traditional territories of many Indigenous nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we're grateful to have the opportunity to live, work, and gather on these territories. The land acknowledgements are only a starting point for larger conversations. More concrete acts of restitution and transformation are needed to address underlying inequities and blatant discrimination in the distribution of resources between Canada's First Peoples and settlers. I'd just like to acknowledge this was developed in the department headed up by Umbrin Najib. Thank you. I'd like to now, I have now the pleasure of introducing our two speakers, many of whom, many of you know either both or at least one of them, Dr. Shelly Dev and Dr. Tina Martimianakis. Shelly, as many know, is a well-known and beloved member of the department. She is a staff internist in Sunnybrook Health Science Center, and she has been working in this role since 2006. She completed an internal medicine residency and critical care fellowship at the U of T and a fellowship in multimedia education at the New England Journal of Medicine. Shelly is a clinician, educator, and associate professor of medicine, director of education in the Department of Critical Care at Sunnybrook, and lead for mentorship and wellness in the Interdepartmental Division of Critical Care Medicine at the University of Toronto. She is an award-winning medical educator of undergraduate, postgraduate, and continuing medical education audiences. Shelly has given nearly 350 lectures devoted to national and international audiences on healthcare worker mental health, burnout, resilience, and medical culture. She has written and spoken extensively on these topics in the wider media as well. But if asked, she would say that her most significant accomplishment to date is her attempts to continue to convince 15-year-old Nathan and 13-year-old Jack that it is beyond cool to be seen with your mother in public. Tina Martimianakis, or Tina Martimianakis, is professor and director of medical education scholarship at the Department of Pediatrics, scientist and associate director, collaborations and partnerships at the Wilson Center and the Temerty Faculty of Medicine at the University of Toronto. As a scientist, Tina studies the social politics of education with a particular focus on issues related to the hidden curriculum and social cultural pedagogies to enable health professionals to incorporate complex negotiations of the social world in their educational planning and implementation. Tina works with educational leaders in the Department of Pediatrics and across the Faculty of Medicine to enhance educational scholarship, to contribute to efforts to improve the learning environment with policy and curriculum innovations. I should also say that she is informally regarded as kind of the heir apparent to Fred Hafferty's title as the founder of the study of the hidden curriculum in medical education, and is clearly one of the major proteges and collaborators of Fred. So these are the folks that we will be hearing from today. It'll be a slightly different format, which we're delighted to hear. And the title of this talk in this format is Understanding the Effects of the Hidden Curriculum. So at this point, I'll turn it over to Shelly and Tina. Thank you.
Thank you, Arno, for that wonderful introduction. Let's see. Can everybody see us in our slides?
Not the slides yet.
not the slide. We just had it. And now?
Nope. Let's see. Why don't you go? Are you on screen share?
Yep.
Ramona, we might need a hand.
Hold on, let's do it this way.
Yeah, of course it was working 30 seconds ago.
30 seconds ago. Does it work now?
Not yet. Tina, do you want to
Okay.
send them to me?
Okay, let me try one more time. I don't believe this. Great way to start. Shelly,
Yes. Do you want me to do it?
hold on.
Let me do it.
Okay, I got the slides again. Let's see. Okay,
Are you able to?
I think so. Hold on. This should work now. Yes?
Ah.
All right.
Looks good. Good.
And if I do
Woo.
this, yes?
Yep.
Yes.
Excellent.
Yes.
Here we go.
Yay. We did
Okay.
it. There, that's it, folks. Thanks for coming.
That was the most difficult part of the day. Okay.
Okay. So thank you so much, everybody, for coming. And before we started, Tina and I both wanted to just take this moment to say that we recognize that this is an extraordinarily difficult and painful time for many of our colleagues, many of our friends, our family members, and our learners. And we just wanted to state clearly and upfront that we are aware of this. And we know that in a talk like this, where you tend to touch on your personal feelings about things and about how we are in the clinical environment, that can be really difficult. And we're aware of that. And we just want you to know that we know it's a very difficult time.
Yeah. And the way we've planned this talk, it's really a conversation that you'll see Shelly and I having, because we wanted to show how some of this work is very much dependent on our lived experience and our appreciation of how the personal intersects with what we do in our workspaces. So while we're going to be touching on a lot of personal things and taking some very vulnerable positions throughout, we don't expect you as the audience to participate with that level of disclosure. You should only feel comfortable sharing what you feel comfortable sharing in this forum. And as Arno has mentioned, we will turn off the recording for the question period, so we can be a little bit more relaxed and have a collegial conversation about how we can move forward with our efforts across the system to revise what we mean by a productive and supportive learning environment. So we wanted to acknowledge that we don't have any conflicts of interest in relation to this continuing education event, except of course that we're both very committed to helping improve how education functions on a daily basis. The objectives for today are related to QI, and they're very much the objectives of many of the departments across TASN, including my own, and that we want to bring some sensitization to the notion and concept of the hidden curriculum. It's a term that's been around for many, many years, but it's appearing in different ways right now because it's become also an accreditation standard. So we want to make sure that everyone understands how that definition is playing out in the work that we're doing, stemming from Royal College work all the way down to our day-to-day practice. We want to reflect on the role of the hidden curriculum in our individual education journeys. We'll be sharing some of ours along the way, and perhaps might inspire you to think about your own education journey in a different way. And we'll develop strategies or we'll role model some strategies for thinking about how the hidden curriculum can support our ongoing reflexive practice as educators, so that we can think about what kind of role we might have in our individual sphere of influence to contribute to QI efforts. So why this topic? Because the hidden curriculum affects how we practice, and it allows us as educators and learners to think about both positive and negative effects and how to improve our learning environment. It's also because this topic, because it relates to the learning environment, it enhances the capacity of learners to learn. And when they can learn better, they can perform better. It also relates, and we've shown with research that it relates to retention, both learner and faculty retention. It improves patient outcomes because it helps mitigate burnout effects in both provider and learners. So that's a brief introduction to why we are here today. But we want to orient the whole talk around this particular case.
So when Tina and I met, we came at this from our shared angles as educators, but our different angles as researcher and teacher and clinician in the teaching environment. I will also say that in medicine, internal medicine, we often quote Osler and all of Osler's clinical findings. And for me, meeting Tina was like meeting Osler for a bunch of you dudes, which is, I'm a huge fan of her work. And so meeting her and getting to work with her has kind of been thrilling. But when we talked, we wanted to come up, with what in our histories brought this out the most. And for me, it's a story that I've told a few times now over the years. And so for those of you who have heard it before, please forgive me, but it truly is a galvanizing experience for me very early on in my career. I was 1 to 2 years in to working as a critical care staff at Sunnybrook. And I was still kind of negotiating that identity formation of what is the leap from being a clinical fellow to being an attending physician. This story, Man versus Coke Machine, revolves around a patient who was in our ICU, and at Sunnybrook, our main ICU is a trauma ICU, so we see a lot of trauma patients. We took care of a patient who was 24 years old, who was admitted to Sunnybrook after an accident at his workplace. And specifically, the accident was, he's a young man that worked at a plant that was a shipping site for vending machines. And these vending machines would be taken to, schools or offices or whatever. And this was the place where they would be taken and shipped out. And this young man was working on the floor where a lot of the machines were, and the machines were often like harnessed by these chain harnesses and lifted up and put onto the beds of trucks. And on one particular day when he was working, one of the machines was being lifted up to be put onto a truck that was much on a different level, a higher level. And this young man noticed that one of the chains had broken and the machine was going to fall. And the machine was going to fall on another worker who happened to be his older brother. And they both worked at that plant. And he went and pushed his brother out of the way and was crushed under the machine. And pretty much instantly became quadriplegic and was taken to Sunnybrook, where he had surgery to stabilize his cervical spine, but was left as quadriplegic. If you ask people about this story in the ICU, particularly the nurses, this is more than 15 years ago this happened, and they would still remember this patient and his family. And it's not an overstatement to say that this irrevocably changed this family. His brother was devastated and racked with guilt. His parents were distraught. This young man was supposed to be married in the months ahead, and he severed his relationship with his fiance, and he was deeply depressed and expressed wishes to be taken off of life support often. It was a really, really awful, awful thing that happened to him. And one day, while we were rounding and doing our daily rounds at the bedside, we ask, as we do in medicine, for the residents to present the patient with a brief introduction so that we can talk about the rest of the clinical issues. And the resident who was assigned to take care of him for that day said, okay, we all know Mr. X. Yeah, man versus Coke machine. We all know the story. And then introduced him in this way. And immediately when he said, we know Mr. X, he's man versus Coke machine, I looked into the room, and the patient, as you all know, when you're quadriplegic, you can still hear, and he was completely alert and sitting in a chair and close to the doorway of the room, and he heard it. And there was a pause, and the space where the pause was furnished with a little bit of laughter. He laughed at his own comment, and it just lit up my ears in that moment. And I was left thinking, how on earth does he know to say that? Or does he believe he can say that? And it was just a very, very jarring moment for me that I couldn't shake.
Yeah. It's a very emotive account. And when we do research on the hidden curriculum, often it's these kind of accounts that underpin a lot of the empirical work that we have in this area. And we have a lot of work in this area. We have over 30 years of research that looks at what makes possible to have these kind of interactions in moments where we're delivering healthcare, when our formal curricula, our educational priorities are completely reoriented to something else, right? So if we were thinking about this learner going through formal assessment or writing about this case, it would be very unlikely that they would be expressing themselves in this way. But somehow there was something in the environment around them, the learning environment that they're in, that was supporting this kind of interaction. So when we think about hidden curriculum work and we talk about the effects of the hidden curriculum, it's stories like these. Now this one is has a negative flavor to it, and obviously it's a very emotional story, and there's lots of components that will come out throughout our talk. But we want to say upfront that it's not only about the negative, it's actually very much about the positive. And we shouldn't be forgetting this. So it's thinking about how and why curriculum and institutions and individuals often in the day-to-day activity of educating and learning while working may not be in alignment.
When we talk about this misalignment or this not aligning, it makes me think of what ideally is what happens to the distance between the work that I'm doing and what gets in the way. So when I'm teaching or when I'm taking care of patients, ideally the distance between me and that has to be like this, so that I can be up close to the patient, up close to the learner, and I can, I can do the work that I signed up to do, that I love to do. And the lack of alignment for me comes when the distance between the two gets wider and wider and wider, and that ends up getting filled with the work of the day, and it ends up getting filled with the priority to move things along. And what happens for any one of us on a clinical day is the emails about bed flow, about repatriation, about who needs to be discharged, about filling out forms, and all of these things that are a necessary part of the workday. And I completely understand that. But what that does is create distance between what it is I really want to do and getting there. And the impact that has on any of us individually is frustration, is fatigue, is impatience. And the way in which it manifests in the everyday of the work is what we feed into our workplace environment. So when we talk about misalignment, for me as a clinician and as a teacher, that happens when getting things done separates me from the work that I really want to do.
And from my perspective as a researcher and educator who helps plan curricula, we learn from these accounts because we want to look at both alignments and misalignments. For the misalignments, we look at things that become systematically misaligned, and then we think about interventions. So that's the evidence base on which we act. But we also we also try to pinpoint places where our implemented curriculum is doing very well, and to learn why and how, and to take those learnings and put them to broader, spread them across the system. So we're actively paying attention, and we're being deliberate about breaking down some of the things that underpin our day-to-day activities. And we're going to walk you through how we might do this by starting very basically at what do we mean by the hidden curriculum as a concept? What's the definition of the hidden curriculum? So conceptually, one of the ways we think about the hidden curriculum is that it's a set of influences that function at the level of organizational structure, culture, and that they affect the nature of learning, professional interactions, and clinical practice. And that's a very sort of academic definition, and it's one you'll see repeated and reproduced in many, many different places, including the way the Royal College is thinking about the hidden curriculum and using it in accreditation. But what do we actually mean by that? What do we mean by culture, structure, and practice? Structure refers to the formal organization of education. It's literally the geography. So where do we place learners and why? Is it the classroom, the hospital, the campus, on community, and the choices and the reasons why we do that? It's the formal course expectations, the timetables, the materials that we designate as learning tools. It's the clinical obligations that we might have, and the policies and regulations that give formality to the things that we do in education. And the thing that becomes a confounder for us is that a lot of healthcare training happens while we're fulfilling another organization's mission, right? The hospital's mission. So we're not only talking about two structures, the university, one structure, the university, which has its own set of policies, et cetera. We need to overlay those in our hospital settings, in our community, and those things might not be in alignment, right? So there's a lot of work that happens at the level of structure to get things to be coherent. And we know that that's never going to be perfect, and we are always mindful of that. We also look at culture because culture refers to beliefs, perceptions, attitudes. It's those written and unwritten rules that shape the meaning that we derive from being in these formal structures. So what does it mean to be sitting together with your preceptor? It could mean different things depending on which organization you're in. That interaction, depending on those unwritten rules, might take a completely different shape because of those cultural elements. And our learners are very adept at trying to make sense of the different cultures, because we put them in the predicament of having to change locations every few weeks, right? So they're constantly trying to keep up with all of those unwritten rules. Then we have process and practice. And what do we mean by that? Well, process and practice are routines, our day-to-day activities, the tasks that we associate with educating or delivering care. And some of these become routinized. There's a particular structure to them, of course, and thinking about what structure being something formal. So there might be policies and regulations that might be giving rise to these processes or practices. But quite often, they're routines and habits we get into. They're habitual. And that's another place where misalignment can happen, because we're comfortable with our routines. We're comfortable with ways, we've always done something this way, right? Always doing something this way might be comfortable, but it might not be fulfilling the contemporary learning objectives that you might have. And this also could create misalignment. And as you can see, the errors are multidirectional, because these things are not siloed. These concepts, we pull them out in order to study different facets of something that's very complex, which is the socialization process. And this is something that's tacit. It's in the background, and it's different from what we generally think of when we think of curricula.
When we're thinking about teaching and learning, we tend to conjure specific images about where that's actually taking place. So the first we would describe as the formal setting to teach, and that would be any type of classroom, any type of lecture hall. It's been prior scheduled, there's a syllabus, there are objectives, there's pre-reading. So this is a very purposeful thing that's pre-arranged. People show up and they know that there's going to be a teaching and learning session. Then the other type would be the informal, what we call, on the fly teaching. And this usually is what happens, what seems to happen organically in the learning environment. So that would be in the clinic, in the hospital, in the emerge, wherever. Now, we call it informal, but there still is a structure to it, in that when you're saying we're going to meet at 2 p.m. for rounds, there is an understanding that there is going to be some teaching and learning happening in that particular setting. So everyone is tuned into the fact that there will be some explicit experiences of teaching and learning. But when we talk about the hidden curriculum, what we're really talking about is what I like to call the in-between times. So it's the space between the informal and the formal moments where we're together. And there isn't this explicit belief that there is some teaching and learning happening, but it is happening passively. It's happening in the throes of the interaction, that there is a learner and that there is a teacher in these in-between environments where it seems like there's no agenda and there is no explicit overt agenda, but there is information being, taken in by usually the most junior or the newest member of that group.
As Arnold mentioned, I'm doing a lot of hidden curriculum work right now, particularly because many of our departments are working on new QI processes in education. They're thinking about accreditation, preparing for it, or addressing accreditation concerns. And as this formality has taken hold about what we mean by hidden curriculum effect and how do we recognize it and then how do we mitigate it, we're starting to pick up some broad system issues, because we're looking at across TASN at some of the things that systematically come up. And there's definitely this issue that, Shelly referred to earlier related to efficiency, feeling the need to get stuff done at the expense of educational activities. And it relates to being under-resourced. It relates to not only the pandemic exacerbated the under-resourced issues that we had, but it creates burnout effects. There's also these lingering, even though we've been trying to do a lot of work over the years, my entire career, there's still these lingering feelings that we need to demonstrate that we need to be all-knowing at the expense of asking questions. And I put we because this is not only a concern for the learners, it's a concern for the faculty. And if it's a concern for the faculty, they're also not creating the kind of role modeling and safe psychological space that we need for the learners to be able to demonstrate that they're not knowing. There's also an avoidance for giving constructive feedback, lest the teacher be perceived as mean or unsupportive. There's also the contrast to this, that the learner is afraid to give feedback to faculty in the moment when it would actually be most helpful, because it might influence their career. And we have a tendency to treat our wellness as secondary to everything else. We don't tell people that we're unwell or that we're suffering. And that culture that values resilient workers has a fallout that we're seeing. And it's while you might think, well, these kind of things are not education specific, they're actually the values, that cultural piece that we were talking about earlier, that creates some of the confounders for some of the formal activities that we want to be achieving in the workplace for those formal learning objectives to actually take hold, right? They become much more powerful signals for the learners. These hidden curriculum effects really have implications for patient care as well. This is an example from a study that we completed here at U of T, and it was in surgery, but it has, again, there's similar accounts across all the departments. I was doing a kidney transplant with a fellow and he was guiding me. Then the staff showed up outside the operating room, and I can see the fellow getting completely nervous, telling me, go faster, when beforehand we were going at a normal, sort of slow pace. We ended up putting the kidney upside down. They ended up putting the kidney upside down because they were afraid to be perceived as not being prepared or not knowing. These are both two trainees, right? Their faculty is there to support them. And instead, the learners feel that they have to know everything before the faculty arrives. They're not asking for help when they need it, and they're not slowing down when they should, right? They're actually speeding up to show that they can keep up with the pace around them.
This kind of phenomenon of the all-knowing and the not asking, I think even in spite of that, we see this in critical care a lot, that every few months there's the reiteration of the point that please call, please let me know what is going on. And virtually every 2 to 3 months is having to dispel the notion that that would be reflective of not being that would be reflective of not being capable, not being able to do the job. So, you know, in the earliest versions of observing the hidden curriculum effects, which took place in primary school classrooms in the 60s, this quote is from one of those papers, that the messages received from hidden curriculum usually deal with attitudes, beliefs, and behaviors, which is what Tina is saying. And this was observed in very small children who, when they left the home environment, went to the school environment and realized that they needed to adjust and they needed to behave in a certain way to fit in with that environment. And and later in the 90s, when that was extrapolated to the medical education environment by Frank Hafferty, it was described more as a socialization process and socializing to what is actually valued in the workplace. And conversely, what is not valued as highly in the workplace. And so we've talked a lot about culture, and we put culture and language under mechanisms by which people get socialized into the medical environment. These are two that we're going to talk about a little bit here. So when we talk about culture, I really like to talk about medical culture because I find this fascinating. And this is the definition that I tend to use when I talk about it, which is the system of shared beliefs, values, customs, and behaviors used to cope with, deal with the world and with one another, transmitted from generation to generation through learning. And I've specifically underlined and highlighted those words to describe what is actually happening. So if we take a snapshot of a day in the life of my workplace in the ICU, anyone who's done an ICU rotation would recognize that this is how we stand. There's an order to how we speak and how we connect and communicate. And that when we're doing that in the first picture on the left, we're demonstrating shared values. We're demonstrating the way in which we think is the right way to talk about certain things, who should speak when and in what order, right? And we do this in order to cope with the environment in front of us. How do we manage or deal with this task in front of us, or what it is we have to deal with? And in the ICU, sick patients on mechanical ventilation or life supports. And when we do this, when we enact all of these things, what we're doing is, to the newest and most junior members of the pack, we say we're exhibiting what we think is acceptable behavior and language. This is how we behave around a very sick person. This is how we talk about them. This is how we talk about their problems. This is how we talk about their families and what their families are concerned with. And that then gets transmitted through learning. So the newest members, the most junior members see this, and much like was observed in the 1960s in the new school environment, those behaviors are adopted, they're enculturated, and then that junior person graduates to being part of that very first picture, a part of the inner circle. And this just keeps repeating itself. And that's the enculturation and socialization process. This is captured in this particular study, where a qualitative study where trainees were asked about this particular process. This quote is very illuminating. You have to learn when it's okay to talk, when it's okay to ask questions, when you need to just kind of be a fly on the wall. I think that's something that no one can teach you and you just have to pick up. So in that quote is just capturing how it is they are learning to just be in the environment and look like they belong in that environment. And it's happening all the time.
Language is part of that, because language is never neutral. I mean, we use words to communicate, and we give words a definition, but they're never neutral. Language actually influences how we make meaning of the world around us. And that meaning changes. The words might stay the same, but the meaning we attribute with those words changes. So that kind of language that we use in our day-to-day activity actually affects how we see ourselves and others, and it contributes to what we come to understand as the culture of a given space. So language and symbols, whether language spoken or symbolically represented, the symbols that we have around us, the way in which we communicate the stress, the way in which we don't communicate the stress, the way in which we show that we want to reward something, or the way in which we want to create something as secondary. It's a kind of valuing that's happening on a given day, on any given day. We're constantly doing it, even when we're not thinking about it. We do it formally because we have to make these choices, and then we're more deliberate, but we're also doing it informally. So we might want to think about what that actually means. How is interaction shaped when we use different ways of referring to the patient? When we say things like a 67-year-old male representing with edema, it might not engender the same kind of activity as if saying Sam Mitchell, who is 67 years old and presenting with edema, or referring to the patient as 67-year-old edema. These are all ways in which we're still communicating across TASN. In all divisions and all departments, we have short forms, we have ways in which we bring the patient into the conversation, ways in which we keep the patient out of the conversation. But you could be saying 67-year-old edema because you might be thinking about something that you're communicating to a peer, and it might be a short form that's accessible, but the patient might be nearby, and not hearing their name objectifies them. And we know from studies that look at how patients feel in our healthcare contexts, when they feel depersonalized by the care that we deliver, they don't feel that they're getting good care. They need to feel that as a person, they are there with us. So language does matter. The same kind of effect happens with our learners. When we use, when we call our learners in the possessive, when we refer to them in their role, the senior resident on service, or when we use their names. It engenders a different kind of immediate relationship to the person near you. I've had learners tell me in sessions that were dedicated just to learners, and they felt safe. And they tell me, this happened in our department, that I've rotated through this one division, and I've graduated from this division, left the division, and nobody knows my name. Nobody has attempted to use my name. They always refer me as the resident. You know, I'm there to do a job. So it's very interesting what happens just by changing slightly and being more attentive to what we're doing in the moment when we're referencing people in our workspace. So, I mean,
yeah, sorry.
Shelly, for me, what was very striking in your account is that there was so much in your account about culture and about modes of communicating. And I'm wondering what your impression is, thinking back now to that time. What was the culture of the division like? How did you perceive it? What do you think made it possible for the learner to come away thinking that it was okay to act like that at the bedside?
I think that really, if I think of all of the moments that led up to that moment, it goes well back into my own training, which is there is a certain way in which I learned to talk about patients. And this is not to, highlight any other people. It's that you learn how to talk about patients. You learn how to present them in a certain way. And part of the culture in the ICU, at least at that moment for me, was that the amount of time that we would spend on different patients would actually communicate what patient tends to come off as more important and what patient comes off as less important by virtue of how much time and attention we spend. And in my world of critical care, definitely, especially for trainees coming through, the time and attention and fascination around acuity, rapidly changing things, procedural things would take all of the focus and the attention and the most of the time that we would spend on rounds. And if I look back at our patient who was quadriplegic, he was settling into that uncomfortable position of being someone who was chronically ventilated and was not progressing on the ventilator to be liberated from the ventilator, and occupied this space of being somebody who we could just breeze by on rounds. We never spent a lot of time talking about him on rounds. We spent a ton of time talking about patients who were acutely unwell and fluctuating and needed titration of medications here and there, or new tests or new consultations. And in contrast, that patient who is becoming chronically stuck or chronically unwell or remaining in the hospital would take less and less and less of our time and attention. And in my head would occupy a space of, this is easy. He's weaning. How's the weaning going? Let's keep moving. And the value I afforded him was not nearly as much as I would have afforded a patient who has quote unquote stuff to do around. So when I was thinking about this in terms of your question about the system and the structure, it's a way in which I also learned to organize my day. The ones who are weaning, easy. We'll just quickly, talk about how's the weaning going. The ones who are fluctuating, interesting, need more time and attention. And if you look at some of the medical education literature around how we communicate value and importance, you can see this when you ask trainees about the intensity of supervision around certain things. There is a ton of supervision around acuity, around procedures, around diagnosis and investigation, and so much less around how to navigate the chronic patient, or how to communicate or spend time with the patient who is dying, or where communication actually needs to be more thoughtfully managed. In my own anecdotal experience, when I lecture on the hidden curriculum every year to the third year internal medicine residents prior to starting their fellowships, I do a quick poll. How many of you have been supervised before doing a lumbar puncture? And every single person will put up their hand. If I ask them, how many of you were supervised directly the first time you had a goals of care discussion or disclosed that somebody was dying or had died? Over 15 years, that number will go down to 20%, generously speaking. And that is reproduced in the literature in terms of how attentive we are at different times. So this transmitted value is by virtue of what we do focus on and what we don't focus on.
Which is what we call in the literature role modeling. And in this particular way that you've been describing the account, Shelly, you're bringing attention to some of the inadvertent negative, perceived negative role modeling when it comes to role modeling the learning objectives, but actually the antidote to hidden curriculum effects that are interfering with our educational mandate is role modeling. This is where we can turn things around for ourselves and within our immediate sphere of influence. And this is where we can use the signals that we have in the broader system to think about how to involve everyone in educational reform so that it's meaningful, right? Umbrella solutions that try to cover too much space lose the nuance. So for your particular case, there's a specific deliberation that you have to go through to think about what is it that I want to make? Where do I want to make an intervention? It's not an easy way to intervene in an entire program to rebalance what you're discussing, right? But thinking about your patient caseload one day at a time, 1 week at a time, allows you to make these changes at a pace that makes sense. So role modeling is a powerful socializing mechanism. And we can see this in the accounts of the learners. They're so adept at picking up who can be a good role model for them and to avoid individuals who might be interfering. When I was a student, I was looking at residents. Now being a resident, I'm looking at staff. When I'm staff, I'm sure I'm going to look at others. And yes, we've documented that happens. It's just a continuous process. And the literature has documented how it's peer-to-peer role modeling that also, this is when we talk to the learners, we always tell them, it's not something that's happening to you. You're part of what's happening and you're contributing to what's happening because you are always a role model to your near peers. Whether you have a formal role or not, everyone is looking to each other to see what makes someone successful. No one wants to be unsuccessful. No one wants to come to work and not do well by their patients. We're talking about individuals who are dedicated and committed learners, otherwise they wouldn't be here working with us. We're also talking about individuals who are dedicated and committed to their patients, otherwise they wouldn't be able to get up every day to go to work. So this is something that is a profound support in us realizing both our healthcare, education, and practice mission.
This particular paper I often give or suggest for people to read. And the reason I like this one in particular is that it does a great job of explaining how these social mechanisms work. And in particular, highlighting where the opportunities are for good things to happen. So if we go to the next table on the next slide, here we go, where I've put the box around in the row for the hidden curriculum, this point about empathic role models and behaviors that convey respect for patients and colleagues. It really, like, we do tend to talk a lot about what are the negative effects of the hidden curriculum, but the very same mechanism provides us with the opportunity, provides me with the opportunity to actually lay it out in a really good way in all those in-between moments. And even more importantly, if we go a bit further, is identifying those things that we don't tend to talk about, which we would call a null curriculum, meaning if we don't talk about certain things, they cease to exist as important at all. They don't even track. And the opportunity to actually talk about things like social justice and patient advocacy, to bring them into the conversation, is I really like kind of envisioning this as a mechanism or a vehicle for doing something really good. So that kind of looking at this really changed my mind personally, and especially as when I looked back on this case.
And in the moment when you were doing that, you were being deliberate, right? So what we're asking individuals to think about in their educational practice is when and how they can be deliberate role models of some of the things that we need to do more of in the curriculum. And that's what we know is effective. The minute you start bringing awareness to your educational practice by naming it, by creating, some space for a conversation, by signaling it to the learner, hey, I'm going to do something a little different today because I want to show you that, X, Y, and Z can happen when we do it this way. That's what makes role modeling effective. If we leave it to chance, then we fall into the trap of reproducing things that are comfortable to us, but might not be the current objectives and where we want our learners to land as we're thinking about reform. So, Shelly, we've used this very personal account to talk about culture, language, and role modeling and how they factor very strongly in education. Do you remember, some of the more routine things like practices that contributed maybe to the reproduction of some of this value system? That's probably harder to remember, but I'm wondering if you think back, were you doing things differently?
Yes. Okay. So I purposely write this as a prologue because I want to be like, I want this to be a play within a play. And what I omit from this story when I tell it is what I do believe as having a major impact on this trainee's decision to say what he had said, which was what happened 5 minutes before he said what he said. The layout of our ICU at Sunnybrook is that there are very few individual patient rooms. It's mostly an open unit. And the patients who are in those individual patient rooms back then happened to be patients who were isolated for recurrent infections, which tended to be patients who had been in hospital for a long time, or patients that we were chronically ventilating who were kind of stuck. And, I, in an effort to sound cool and disaffected, had said to my team as we were about to go to the back hall, okay, guys, it's time now. We have to round in the ass of the unit. That's literally exactly what I said. And when the next moment happens, and of course, I am met with obliging laughter when I say it, which I thought was so sophisticated and wonderful of me to get that. We go to the back, and just a beat after is when we hear man versus Coke machine. And I'm struck by this. And this literally was the moment that it works out in time where I was learning myself through my own education, scholarship work about the hidden curriculum and learning about this and really having to implicate myself in what had happened here. And the truth is, what really happened here clearly was egregiously bad behavior on my part, but also my not having learned how to speak honestly about patients like this. So whether they are the alternate level of care patients that Jillian pointed out in the chat, patients who are waiting for placements, whatever, I never learned to say patients like this really make me feel impotent. They make me feel like I haven't done my job. They make me feel helpless. They make me feel sad for them, and I don't know what to do. And so in speaking about role modeling into, this is a long way to answer Tina's question, is that the reason I tell this story, and it's hard for me to tell this story because I feel ashamed of it, but the reason I tell this story is to remind myself that that was a missed opportunity, because after he said what he said, I didn't say anything. I never went back to him. I never corrected the behavior. I just sat there stunned and just tried to move along. And what I do now is when we have patients like this, I very deliberately, to use Tina's words, say, you know what, guys, patients like this are not the reason I thought I wanted to get into medicine, because I wanted to get in to fix people. But I've realized there's a lot of patients like this that I need to think about how to help them achieve a certain outcome, the best outcome possible. What is that going to be? And when we do have patients like this, what I will ask the residents to do is please, at the very least, go in and spend 10 to 15 minutes with this person and just talk to them. Just see how they are and chat to them. Because I do think a lot of the time, every time I give this talk, about the trainee that I did not speak to after he said this. And I think about all the people he would have talked to after that 15 years ago. And what a missed moment that was for me. Yeah.
But it's a work in progress, Shelly. And I think that's what we want to leave our audience with today, that we're all working towards a psychologically safe and productive learning environment, one step at a time. And there's stuff that we can do at different levels. We spoke about structure, culture, practice. We can as you have over the years and what you've been describing, we can think about different levels at changing and interrupting some of these practices. And I'm looking at the time, so I think we're going to land on the space that, just to remind everyone that what we're doing when we say we're socializing is we're doing identity work, right? And this is where the personal intersects with the professional. And this is where a lot of our moral distress is located. And that's why the hidden curriculum literature can be an important place to go to when you're thinking about resolving and making changes in your workplace. And there's lots out there. It's 30 years at least of work in our field. And I want to leave you with, we want to leave you with Liz Goffberg's words. Every time we make a choice, react or don't, repeat unprofessional behaviors or seek out more admirable ones, we're feeding something back into our medical culture. It's our culture, right? It's all our culture. We have the opportunity to shape it. And what has changed, I think, Shelly, you would agree, is that we have the support of leadership and institutions. And right now is the prime time to think about how these things play out, given the Royal College's focus on supporting educational reform in this direction. Shelly?
Thank you guys so much for giving us your time and your attention, and hope, and just being open to considering all of this, this big complex concept. We know we went right to just past time. I don't know if we have time for comments or questions, but we would love it if we did.
How about let's have one question.